Gage. I am a second-year resident at the pathology department at the University of Tennessee in Knoxville. So today I'll be talking to you about HER2-positive breast cancer in the pre- and post-adjuvant anti-HER2 therapy era, and it's based on our experience at our institution in the setting outside of clinical trials. So a little bit of introduction. I'm sure most of you know all of this already, but HER2-positive breast carcinoma has traditionally been considered unfavorable because it's been considered quite aggressive in nature and associated with a high mortality rate. It's generally associated with high tumor grade, high cell proliferation rate, and a high frequency of visceral metastasis, and it's often associated with estrogen and progesterone receptors negativity. Anti-HER2 therapy was first approved by the Food and Drug Administration in the United States in 1998 for HER2-positive metastatic disease. And then since 2005, it's been used as an adjuvant treatment for operable HER2 breast cancer. And this was shown, this adjuvant use of anti-HER2 therapy has been shown in at least 2 major randomized clinical trials, such as the 2 that are displayed up there, to reduce the risk of recurrence and to improve overall survival in patients. So the objectives of our study was to ultimately evaluate whether adjuvant anti-HER2 therapy has a similar beneficial effect on survival in the setting outside of clinical trials. Most, if not all, of our data that is published and existing right now is from the clinical trials, which, as you all know, is a highly controlled population of patients that are studied in those. So we wanted to see if the therapy was similarly beneficial in community-based practice, which, needless to say, is less than highly controlled. So we looked at Caucasian females at our institution with HER2-positive breast cancer, and we looked at their clinical-pathologic characteristics and measured their overall survival while comparing the treatments that they received before or after November 2005. The reason we chose the date November 2005 was because that was the implementation of adjuvant anti-HER2 therapy as standard practice at our institution. And this was subsequent to Roman's study in the New England Journal of Medicine that was published in October of 2005 that showed a significant improvement in disease-free survival in patients who are treated with adjuvant anti-HER2 therapy. So we looked at HER2-positive breast cancer patients between the years of 1998 to 2009 who had stage 1 through 3 disease. That yielded 167 patients. We then divided those patients into 2 groups. Group 0 were the patients that were diagnosed before November of 2005, and then we had 78 patients in that group. And we had group 1, which were the patients diagnosed after November 2005, and we had 89 patients in that group. And then we further divided the 2 groups into the HER2-positive subtypes. So this is just a schematic of those methods. As you can see, we started with 167 HER2-positive breast cancer patients that were followed between diagnosed between January of 1998 to December of 2009 and followed for less than or equal to 108 months. We then divided them into group 0 and group 1, and then we further subdivided each group into luminal B or ERPR positive subtype, and then ERPR negative or non-luminal subtype. And as you can see, the number of patients is relatively well distributed among the 4 subtypes. So these were some of the results we came up with. At the top, again, you can see that they're relatively well distributed among all 4 groups. The age was about the same in all of the groups. It was about 55 to 57 years old. The most common type of breast cancer among all 4 groups was invasive ductal carcinoma. The most common grade among all 4 groups was 3. The size was consistently greater than 20 millimeters of the cancer. The TNM anatomic stage is interesting because stage 1 and group 0 non-luminal subtype and group 1 luminal B subtype both had stage 1 as their most common. And then stage 2 is most common in group 1 HER2 non-luminal subtype, And then stage 3, interestingly, was the most common stage in group 0 luminal B subtype. And you can see down here that the alive patients at 108 months was around below 50% in group 0. And then in group 1, after November 2005, it jumps up to about more than 85%. So the treatments that these patients received, the most frequent surgery type was across the board was a modified radical mastectomy. Radiation therapy was about half across the board. Hormones received both before and after November 2005 was about 85%. Chemotherapy received is interesting because you've got about 65%, 70% in group 0, but then in group 1, it jumps up to 95%. And that corresponds with the anti-HER2 therapy that they received, and they received it in about similar proportions as the chemotherapy received. So the clinical pathologic characteristics, the tumors were mostly high grade. They were greater than 20 millimeters in size. G0 had a 53.8% mortality at 108 months, whereas in group 1, they had 73% of them received adjuvant anti-HER2 therapy, and they had only a 13.5% mortality at 108 months. And ER/PR phenotype did not appear to have a significant impact on overall survival. So this is a Kaplan-Meier curve. The top line there represents the group 1, or those that were post the anti-HER2 adjuvant therapy era or after November of 2005. And then the bottom line there is the group 0, and you can see that there's a fairly significant gap between the two. And this is the Cox regression curve when it's controlled for age, grade, and T&M stage. And again, you see a significant improvement in survival. These are the subgroups with the ER/PR phenotype included. And the top two lines there are the group 1 with both subtypes, and then the bottom two lines are group 0 with the two subtypes. So you can see that ER/PR does not have a significant effect on overall survival. And this was interesting. It's group 1, some of them did not, between those who received anti-HER2 adjuvant therapy versus those who did not receive anti-HER2 therapy. And there's no statistical difference. However, this is probably most likely due to a lack of statistical power and a limited sample size. So our conclusions were that overall survival was significantly improved in group 1, or those who were diagnosed after November 2005 versus group 0. And this supports adjuvant anti-HER2 therapy as a valuable treatment for significantly improving survival outcomes in HER2-positive breast carcinoma in the settings outside of clinical trial. Community-based data on overall survival is just starting to emerge now. And so as we accumulate data from more patients and use databases such as the SEER database, we can create more statistically powerful studies that will, that I predict will show or support these findings. And thank you.